Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today it is my distinct pleasure to introduce you to our guest who will be helping us with exploring and supporting the positive in medicine. Dr. Benzie Kluger is the Julius, Helen, and Robert Fine Distinguished Professor of Neurology and the Director of the Palliative Care Research Center at the University of Rochester Medical Center, New York. He is an internationally recognized leader in the emerging field of neuropalliative care, the founding president of the International Neuropalliative Care Society. His work has been funded by the NIH, the Michael J. Fox Foundation, and many, many others. And on top of all of that, when I explore some of his projects online, which you can see at benziekluger.com, I'm struck that the very first word he uses to describe himself is as a human. A human that cares about advocating for people with serious illness, a human who literally calls out the BS in the healthcare system. Benzie, thank you for being here and welcome.
Well, thanks for having me. Warm introduction.
Yeah. So, for our audience, our format today is going to be more of a conversation interview style for about 20 minutes or so. And then we'll open it up for some questions from the audience. So, Benzie, we need to set the stage for those that have not heard of this before. So, would you be so kind as to give us a nice little short and sweet explanation of this concept of total joy and what it is that you're advocating for us to do?
Yeah, sure. I think to give you a little bit of background, it was something that, well, I guess like a lot of things in my life happened spontaneously and in an unexpected place. I was in Colorado at the time, and we had started seeing patients for evaluation of medical aid in dying, which is not where you would necessarily expect to see joy popping up. But I think one of our first patients, our chaplain was talking to, we were trying to figure out, kind of what the right timing was and what to do next. And our chaplain asked I think, simple question of, where do you find joy in your life? And she said her family. And then he asked, how much more time would you like to spend with them? And she looked at him like he was an idiot and said, a lot more, of course. And that kind of changed the trajectory of things, where we ended up supporting her in hospice. She did end up using medical aid in dying, but that was kind of this pivot point. And as a team, I think it got us to thinking about how many other opportunities for joy are we missing? And should we be doing this more systematically and routinely, the same way that I think in an ideal world that we would be systematic and routine about assessing total pain. And so that was kind of the birthplace of it, and it's definitely evolved since then. But that was really the starting point, was to think about how can we find opportunities for joy. And I think one thing that may also tie into why I'm particularly interested in that is in neuropalliative care, working with Alzheimer's disease, with ALS, with Lewy body disease. I think hope for a cure is just not on the table at all. And so the question comes up, and actually a talk I've given before to the American Academy of Neurology is, how do you steal victories away from incurable illnesses? And I think one of the tools that we have for that, if we are looking for it, is joy. And we've had some amazing, some amazing things that we've worked on with patients to bring joy into their lives. From early on in Colorado, actually, our social worker connected a MS patient with quadriplegia with a group that did skydiving for people with disabilities.
Wow.
One of my favorite patients passed away this summer, and we were always doing our visits. They were in an RV that was modified for her PSP. And so she would be on Havana or Savannah, going down Route 66, doing other things. People having family reunions, sometimes just eating ice cream every night. But a lot of ways that you can find joy, even with a neurologic illness.
So that statement, how do you find joy? The very first introduction, and in all of your papers, you've got lots of examples of different ways you can ask people about joy. But what do you use? What's your go-to phrase? Why do you think it lands as well as it does?
I think the things that I will almost always do, even the first time I meet somebody, is ask them what's the toughest part of this for you, kind of standard palliative question. And then second question is going to be, what do you enjoy and what do you look forward to? And that sometimes helps. Sometimes people will say nothing, in which case then I'll ask people, tell me about your life before this illness. And between those two questions, we usually are able to get some things to work with. Those are things that we do on the front end. On the back end, as we're closing a visit, and it really depends. I mean, there are some visits, and when I've given lectures on this, people will, have the concern that, that we're moving into toxic positivity. And so there are definitely times where it is, it doesn't feel right. It doesn't seem sensitive to talk too much about joy. But I would say, and maybe to the surprise of some of the fellows and residents who work with me, that it comes up more often than you might think it would. And so even after a heavy visit, there may be a point towards the end of the visit where we're talking about, grief or loss or pain. And I'll say a phrase, something along the lines of, I want to make sure that, we address those things, but I also want to make sure we don't lose sight of the fact that you're still alive and that there's room for love, joy, connection, and meaning. And so that is kind of this transition point at the end of the visit where we might open things up to talking about, what could we do over the coming weeks or months that might, make your life a little bit better. And sometimes, as I said, it could be a big thing. Sometimes there's a big obvious thing, like there's a trip or a family reunion or something that somebody wants to do. But a lot of times it's small things. It's listening to more music. It's watching movies. It's, as I mentioned, ice cream. It's holding hands. It's touch. It's maybe spending a little bit more time in nature, even if you can't experience it the way that you used to. And I think actually when we were emailing back and forth, one of the things that also sometimes comes up is just in closing, a heavy visit is just giving people the suggestion or encouragement to do something nice for themselves that evening or over the weekend. So have a nice dinner, drink a glass of wine, watch a funny movie, do something kind for yourself.
From a pragmatic standpoint, so I've got my template, my goals of care template,
Yep.
which of course is like a starting point, and I never end up following it, right? Because you have to move with patience. But okay, so I start roughly there, and I have similar questions. What are you worried about? Suffering? Tell me that component. I have the total sort of joy components. Are you alternating positive, negative, positive, negative? Do you like to get out the negative first and then move on to the positive? How do you practically try to find that balance between the two?
Yeah, it's a good question. I think the way it usually works out is that I'll ask people early on just to kind of tell me a big picture about their overall quality of life.
Hmm.
And if people's answer to that is it sucks, then we'll start with the suck.
Hmm.
And if people tell me that it's pretty good, we'll start. I'll say, tell me more about that. How's your life doing well? So that usually dictates the initial direction, but I am pretty systematic about making sure that we touch on both, even in people who are in pretty dire circumstances. We'll still talk about it.
Sure. You, your work primarily is in the outpatient clinic world. Is that
That's
correct?
right.
Okay,
Mhm.
all right. Because many of your examples that you offered, um, they sort of fit with that mold, somebody you're going to continue to see, you can follow up on if they've done these things. I work in the inpatient consult world. I may never see these people again. And
Mhm.
so I find that I end my encounters differently just by the nature of that. And the most positive thing I feel like I can offer people is maybe less about what I'm recommending they do and more about me trying to offer them some hope, some care, some empathy. I mean, almost always I'm ending my meetings with no matter what happens, we're going to do a really good job of taking great care of you. And that may be because things are so dire here in the hospital,
Mhm.
rather than in the outpatient world. Um, so you have been thinking and practicing about some of this positivity for a while now. Would you be able to share with us an example of where you've stumbled in some way, landed on a landmine of some sort?
trying to think about that. I mean, I would say for the most part, things have gone pretty well. There have been times where I've been positively surprised. Actually, just happened over the last month, where maybe I wasn't positive enough. There was a patient I've been caring for, and myself and people in our group also do house calls. And this is a woman with ALS who's advancing, is using her BiPAP more often, is moving to a wheelchair. And I was meeting with her and her daughter, and we were talking about things. I don't remember how we got on it, but I think I had brought up earlier. Maybe I think I brought up even before we did our exam the possibility of maybe getting a wheelchair van or trying to do some outings and things like that. And then after the exam, I think I didn't want to raise her hopes up, and part of it might be my own transference because I remember when my father-in-law was dying, that I really wanted to do more with him than I think he wanted to do. And I think that's a disadvantage that we all have as clinicians is that even if we're seeing people over time, we're getting a series of snapshots, and so we don't always know people as well as we think we do.
Hmm.
And so, my vibe and part of it might have been my transference was that, maybe this is a situation where the mom, the patient with ALS, isn't going to want to be pushed into doing things. And I definitely have had some situations where we've encouraged people to do something or take a trip. And occasionally, not too often, it ends up being, a big effort and, can be a big disappointment. Um, and the flip side, and the flip side actually happened with this patient, is that it sometimes ends up being wonderful. And so they ended up just recently renting a wheelchair van, and she sent me a picture. They went to what's been called the Grand Canyon of the East, and had a great day outside, seeing the fall colors, and was totally worth their while. And so I think the caution there is to not yeah, I guess just as we can't take away people's pain entirely, we can't it's not up to us whether or not people are going to be able to have joy. And so keep giving people the benefit of the doubt, I think was my lesson there. And it definitely happens other times too. I think I like to try to be systematic about things, but there are times where my inner gestalt tells me to go one way, and then sometimes the student or resident or patient's family goes the opposite direction, and it works out well.
We have bias even in our own desire to bring joy to other people. Man. So as a neurologist, are there some particular challenges to this concept of total joy that may be a little bit unique to the rest of us?
Definitely. Yeah, and well, yeah. I'm sure you see a good share of neurology patients as
Yep.
well. I mean, these are, I think several of the challenges that come up is that neurologic illnesses attack the person. And I think maybe a place to start about, I think in one of my papers, I talk about this, about why joy is such a serious topic, is that for example, when people with ALS choose medical aid in dying, its number one reason is loss of ability to do joyful activities. And so that is, yeah, I think as much as I'd love there to be joy, right up until the last moment, that's just not the reality for a lot of people. And, we wouldn't be sensitive to try to make that the reality. And so acknowledging that limitation, oftentimes that's a sign to me that, maybe it's time to start working on letting go, giving people support in doing that their time and their mission and their joy and stuff is done. I mean, so in some ways, joy or lack of ability to experience joy then kind of becomes a bit of a thermometer, I think for myself and the family of, how can we help this person transition to dying, transition to whatever is next for their soul and spirit. But that they've just kind of reached the limits of what anyone could expect for them. And I think that's part of the ALS story too, is not wanting to burden somebody with a neurologic illness with our desire for there to be joy and love and meaning in the world.
Hmm. Side note, I I saw in your paper with Bob that there was a struggle to figure out what word to use as the counterpart to total suffering.
Right.
You you still like the word joy?
I do, and
Hmm.
I don't know how well you know Bob, uh, but yeah, Bob didn't like the word joy,
I
so
could
that was
tell.
one
I
of.
could because he put his name initials next to it that he had struggled specifically with it. Yeah.
Yeah, yeah. So we've wrestled with it. I think I'm more comfortable with it,
Mm,
and thinking about it as a yeah, as a positive counterpoint, and thinking about joy. I think almost in a spiritual sense as something distinct from happiness.
mm,
And I think Bob's issue with it, which I definitely can understand and respect, is that he felt that it was yeah, too positive. Like it was too great of an ask for people to try to connect to joy.
mm,
And I think as I've worked with different people and fellows around this idea, is it seems like what's most important is finding something that you know what it means and that you're comfortable with and that
mm,
you're able to work with it. I've
mm,
had other people say, how are things in your heart right now? And for that to me doesn't work, but for other people, that works well. But for me, it works. And I guess in some ways it is asking a lot of people. And at the same time, we're only on this planet once, and people do amazing things. And, I really try to the work I do, I really do want to make it soulful, and I really do want to, yeah, I feel like medicine is a spiritual practice for me, and so I don't want to, not go down certain paths just because they may be challenging or a struggle. I mean, that's something I think probably all of us in this room have seen is just learning from the grace and courage and strength and humor of the people we care for of what's possible in this life.
mm. I have one more question for you before we open it up to the audience. So if anybody has a question, raise your hand, type it in the chat. We'll call on you in some way. But my last one is that how has your concept of this changed over time, right? You've written multiple papers on this. You've been chewing on it with yourself, your learners. Where are you at these days on this?
Yeah, two things that have come up. One is I would say a kind of an extension of this idea, which comes up, I guess, as if you teach something or say something enough, then maybe you'll be impelled to actually do it. And so as I've been giving talks, I have a slide that compares problem focused care from goal focused care. And I would say that's been something that me and our group have been doing a lot of recently with some patients who are labeled as difficult or challenging. Often, some of them have chronic pain, some of them have functional neurologic illnesses, and we've really had some sweet shifts happening. Really almost transformational visits where we've gone from, I don't know, trying to bang our heads against their problem list and instead really try to work on, what are your goals? And let's create a goal list and let's see what we can do to start moving you towards your goals, some of which may involve tackling your problems. But I think leading with the goals, leading with what can we do. And I think some of that takes us as a team into some uncomfortable places. Like for one of our patients, we ended up going, I think, a little bit higher than we would have liked to with their oxycodone. And we had a nice conversation, including about our own discomfort and how we're being honest and vulnerable with this other person. But it ended up working out because we had set a shared goal together. And we had said, this, slightly higher dose of oxycodone is only going to be worth it, I think, if you're able to, get out more, go see a concert, do some of these things. And I think, that kind of quid pro quo ended up working out really well. The other thing I'm been thinking about, I don't know where it's going to go yet, is just figuring out how can we create spaces where the positive and negative are equally welcome.
Mm,
Um, and so, and I've been thinking of that, I think also in part in terms of research that we did a project with a woman, Judy Moskowitz, who's an amazing psychologist and has done a lot of positive interventions. And I think some of the pushback that we've got from some respondents is, yeah, it's not quite toxic positivity, but it also didn't quite ring true to them. And so, really trying to, to me at least, I think it's obvious that we don't want to dwell just in total pain. That's not a pleasant place for patients. I don't think it leads to optimal outcomes. And at the same time, I think having interventions that are grounded just in total joy are also going to be invalidating for some people. And so, thinking about moving forward, how do we have like the full rainbow of emotional flavors and be able to support people fully in both? I think part of my push for total joy is just that it's going against the grain of medicine, and so I feel like it needs an extra push. But I think the sweet spot would be a place where, as I would often end a visit, that we make space for your grief and how much this illness sucks, and at the same time that we make space for joy and that you're still alive, and how do we, make the most of this one wild, sweet life while we have it.
Yeah, that kind of gets at one of the comments that are here in the comments section. So Nicole writes, introducing the concept of joy in the face of a terminal illness does sometimes feel insensitive and just not where the patient and family are emotionally and mentally. Those introductory words that can help them understand why I'm asking joy questions and why am I even talking about joy are important. It's not a natural headspace to be in.
Mhm. Yeah, well, I think that transition I mentioned earlier of saying, this totally sucks. You have every right to be sad and upset. And at the same time, I don't want to miss any opportunities we might have, for joy and for love and connection and meaning. The other angle on it too is that, joy and love and connection, can be a way to help deal with some of the suck. And so it can be something that we explore together, not to deny the suck, but it's something that we explore together as a way that we might be able to cope better, find resilience, make the best of a crappy situation.
Yeah. I think you've answered sort of the question that f fell under there. What are some ways of exploring this? Just like you mentioned, you have now used the word suck probably 4 or 5 times. I enjoy using that word as well. Is that something that you also use with your patients, or is this more of a medical team talking to each other?
No, no, no. Well, I mean, I'm sure you've had it come
Mm-hmm.
up as well. I mean, people will use
Mm-hmm.
the word suck. Uh, if
Mm-hmm.
they use the word suck, I'll repeat it. But oftentimes, suck is the best word.
Yeah.
So even if patients don't use it, I will. It depends on the patient.
Mm-hmm.
But I would say 90% of the time, if I say, this sucks, or this is a shitty illness, or whatever, like that resonates. And I think that can be, yeah, that can be pretty powerful and pretty validating. Just speaking within neurology, but I assume it's true in oncology and other aspects of medicine. It's pretty rare where people really acknowledge just how much things suck, and finding physicians that are willing to go there and willing to, go down in the hole with you and, just say, this is horrible. There's nothing, it's hard to imagine, having worse news or being in a worse situation.
Yeah. All right. One more comment that I want to share with you, related to positivity, but it feels like it's a bit of a ramble and out on a tangent. Um, so I worry okay, again, inpatient world, so a little bit different, but I worry about the patient who cannot see any positivity. I mean, we're talking like 0%, like a viewpoint that feels so extreme to me. It almost feels like it lacks the nuance of what most people's reality is. I'm not saying it's impossible, but it seems that's a red flag to me. And so there's a particular pattern that I see this in. So you've got somebody who's hospitalized for a really long period of time. They've had a couple of setbacks, loss of control, loss of dignity, loss of humanity, and now there's this final straw that happens. And this patient tells the team, I want to die. I want to die today, not tomorrow. I want to die today. Don't call my wife. She doesn't need to know about this. I want an injection. And of course, the palliative care consult, right? How do we navigate this? And when I meet with them, what I'm struck by is this hyperacute change, like a 180-degree turn, where they have this inability to see any positivity for the future. And that's my red flag that says I need to slow things down. I need to make this person feel heard. I need to make them feel more like a human again. And almost invariably, the next day, they say, wow, I was so frustrated. Thank you for sitting with me. I actually don't want to die. And so positivity can be a red flag for all sorts of other interesting things as well.
Hmm. Yeah, I thought you were going to go in a different direction with that. Although I could see
Oh,
that happening in the
hmm,
inpatient setting.
hmm,
But I have encountered it, and maybe you have as well, of people
hmm,
with what I would call terminal demoralization.
hmm,
And it's kind of similar, kind of two things at least I see sometimes in the outpatient setting, and I haven't found a way yet. I mean, they're both situations where I feel like you have to be very cautious with introducing joy. One is having a burnt out caregiver. It's very hard to unburn somebody out.
hmm,
Uh, there's people who have distress and are on their way there, but when people have kind of like crossed this line of burnout, and they just can't do it anymore. It's like very, yeah, I would say it's a pretty sensitive situation. And the patient equivalent of that is that, sometimes I'll meet people who have reached what I would call terminal demoralization, where, I don't think they're depressed. To use crude language, I think they're just done with the shit.
hmm,
And they don't, they don't have hope. They're just looking for an exit. Um, and yeah, I mean, I kind of like you, I try my best to connect. I want to be a person with them on that journey. I've definitely had people who've had relief to be validated in that space, to have somebody who's willing to go with them to help them to let go. But I can't say I've had somebody uncross that line. I mean, I would say that was kind of a lesson early on that I had somebody, when I was just getting into palliative care and I was,
hmm,
thought it was the new gospel and that I could palliativate anybody. And this
hmm,
person had been
hmm,
denied for DBS. They had
hmm,
Parkinson's. I wasn't even sure they met full criteria for hospice, but they had just lost their will to live. And fortunately, part of me listened to them on that, and we got hospice started, and they died within a month. But there was a part of me that really wanted to bring some joy and love and meaning back into their life, and that it didn't happen. The best I could do was support them in their letting go.
And I wonder if the difference between sort of our two sort of examples in the different direction is that in more mine, it was emotion sort of clouding reality, whereas you talk about sort of the completion of things and the finality of disease and stealing away somebody's humanity that can't necessarily be given back. Yeah. I've got one more question here from Eve in the comments, and I think we'll conclude. So,
Sure.
I had a chaplain tell me she feels people of faith are more likely to experience joy and purpose in the face of serious illness. Do you feel that faith is a key component in joy?
It helps. Yeah. And never, well, actually, we're working on publishing it, but we
Hmm,
did a study. I don't know if you're familiar with the McGill quality of life instrument, but it has a place that you can write in
hmm,
what's been the most important thing for your quality of life over, I think, the last 2 weeks.
hmm,
And these were over 200 patients with high palliative needs. They were part of a palliative care study with Parkinson's. And over half of the responses were positive. And I think it was interesting to me, but I would say that the two areas where I think traditional quality of life instruments fail is that they don't account for faith. And so one of the areas where if you do a traditional quality of life scale and it looks like their disease sucks, and if you talk
hmm,
to them, they say, no, my life's great. Sometimes faith and religion can be that difference.
hmm.
The other one that commonly comes up is that difference is family. So if people have a very connected and supportive family, that they can have, quite a bit of joy despite everything else happening. And then there, certainly people who can be spiritual and have a humanistic bent and find joy through other things. But I would say the vast majority of people, it ends up being religion or family or both that, ends up being their light in that dark time.
Well, Benzie, we really appreciate you joining us today. Thank you for all the work that you continue to do.
Thanks for having me. It's been fun.
Absolutely. All right. See you, everybody. Bye.
Take care.